In this particular section, we are going to discuss on hypopituitarism, even though it's a short section, and the most important aspect of this section is to understand the investigational aspects of hypopituitarism, because that is the one that's going to be an exam question. But even though it's also of paramount importance to understand the etiologies of hypopituitarism, which will also be carried away to the future subsequent topics. That's why it's a really important video once again. So what are the causes and etiologies of hypopituitarism? That's what we're going to see first. So when you discuss about the etiology of hypopituitarism, the first thing that comes into my mind and that should come into your mind is on the mast lesion. So mast lesions can produce hypopituitarism. So mast lesion in the sense, it could range from anything. It could start from pituitary adenoma to a carcinoma to a metastasis to the pituitary, or even some very benign disorders like cystic lesions. All these things can produce mast lesions. Because these mast lesions can produce compression of the pituitary, or you can write as compression of the normal pituitary, normally secreting areas of the pituitary, they can result in compromise of these areas and can result in reduced secretion of hormones from these areas. So that is why any mast lesion can produce hypopituitarism. You can ask me, sir, we have always seen pituitary adenoma is going to produce hyperpituitarism, excessive secretion of a hormone. You are telling it's hypopituitarism right now. It's relative. You have to think in a relative fashion. So for example, if you have a pituitary, and let me assume you have a mast lesion, probably in this example, let us assume this is a somatotroph adenoma, which means it's a functional one, somatotroph adenoma, that is going to secrete growth hormone in excess, and the patient is having a acromegaly. Suppose the tumor is so large enough that it compresses on the adjacent structures, which means it can result in compromisation of the other normally secreting areas, which means there can be reduced secretion of other hormones of the adenohypophysis of the anterior pituitary, reduced secretion of other hormones. So this is absolutely possible in these patients. So that is the reason why I told you, even though one hormone tends to be relatively higher in case of a pituitary adenoma, the other hormones can be relatively suppressed as well. So that's why, even though it's a classic hyperpituitarism state, still they can result in hypopituitarism also. It's all relative to each other, so you have to understand that thing much better. So this is really important to understand. So mast lesions can produce hypopituitarism in selected patients. If the tumor is very big, or it is causing compression of the adjacent normally secreting areas, so you might result in a hypopituitarism picture. All right. So number one. Number two, you can get in a patient who has underwent a pituitary surgery. Currently, the most commonly performed pituitary surgery is a transfemoral surgery. After this, you might result in a hypopituitarism. Well, number three, you can end up with hypopituitarism after pituitary radiotherapy. So, or any brain tumor in the childhood, if you are going to irradiate them, again there is risk of developing a hypopituitarism, because pituitary is a little bit radiosensitive. So when you develop a hypopituitarism, usually there is a lag period. You don't develop immediately. Usually develop approximately after 4 to 5 years after radiotherapy. This is again a very important question in exam. 4 to 5 years after radiotherapy, you might develop hypopituitarism when you go for either pituitary radiotherapy or a radiotherapy for a brain tumor, possible. Number four, if you are having an infiltrative lesions can well cause hypopituitarism. So what are the infiltrative lesions? You have a TB, you have a sarcoidosis, you have hemochromatosis, a lot of infiltrative lesions. Hemochromatosis, all these things can produce hypopituitarism. Typically, your TB, sarcoidosis, hemochromatosis, all these things will first affect the posterior pituitary. That's a very important point, because I told you these infiltrative lesions and metastasis are going to first affect the posterior pituitary, and the usual presentation of these will be in the form of a diabetes insipidus or a cranial or a central diabetes insipidus. So that's how they are going to present, because of the loss of ADH secretion. Clear? But there is another infiltrative lesion that's called as lymphocytic hypophysitis. I think I would have mentioned in the last video itself, lymphocytic hypophysitis, which is actually going to present with problems of the anterior pituitary. That's a very important point. This is the only infiltrative lesion that usually presents with the problem of anterior pituitary adenohypophysis, where you are going to have ACTH deficiency very commonly with this disorder. We'll discuss in some time. Again, in great detail, maybe in the next video when you are going to discuss about the mass lesion, that time we will discuss. But right now, I'm just going to tell this is an infiltrative lesion. Among all the infiltrative lesions, this has a maximum propensity to produce a antipituitary problem than a postpituitary problem. Apart from that, METS infiltrative lesion means it's a postpituitary disorder resulting in presentation with the diabetes insipidus. Okay. Number 5. So if you get an infection or an abscess, example for an infection and abscess is cavernous sinus lesions like cavernous sinus thrombosis or meningitis, especially tuberculous meningitis can result in this problem. So infections and abscess formation. Number 6, you can get with a condition called pituitary apoplexy. So where it is due to ischemia or infarction of the pituitary. It could be due to ischemia and infarction of the pituitary, or it could be due to hemorrhage into the pituitary. It could be due to hemorrhage into the pituitary. So both conditions are called as apoplexy. But even though there is a subtype of apoplexy which is considered as a separate disorder called as Sheehan syndrome. Sheehan syndrome. Remember, Sheehan syndrome typically happens only in the postpartum woman after a postpartum hemorrhage. Usually after PPH and severe hypotension, you get ischemic necrosis of the pituitary. That's what we refer to as something called a Sheehan syndrome. Even though the clinical features I'll be discussing in some time, the Sheehan syndrome, and depending on the textbook you study, the Sheehan syndrome, they will give as a subtype of a pituitary apoplexy, or they will give as a separate disorder, because some authors do consider the Sheehan syndrome as a separate entity and they don't put under apoplexy at all. So anyways, so it's a postpartum necrosis of the pituitary that is due to hypotension during the postpartum period, especially after postpartum hemorrhage, you get the Sheehan syndrome, because the presentations are completely different. The reason is because this apoplexy tends to present in a very dramatic fashion. Like they will be very acute in presentation, like headache, visual field defects, and all these things. But the Sheehan syndrome tends to produce more subtle manner. It's not going to present very dramatically like pituitary apoplexy. In the sense, they are going to present more subacutely or even in a chronic fashion. That's how they're going to present. Clear? So we'll see the difference in some time. But remember, ischemic necrosis of the pituitary or infarction of the pituitary or bleeding, hemorrhage into the pituitary, if it happens in a non-postpartum woman, we call it as apoplexy. If it happens in a postpartum woman, it's a special type of apoplexy, or even if you can consider as a separate disorder called as Sheehan syndrome. Clear? Alright. Number 7, you have a entity called empty sella syndrome. This empty sella is something a little different entity, because what do you mean by empty sella? The name itself suggests you have a sella turcica bone and the pituitary should be there in the sella turcica, and if you don't find pituitary in the sella turcica, that's what we refer to as a empty sella, which means you don't have pituitary, in the sense the CSF is going to fill that area and you don't see any pituitary in the sella. So this empty sella could be pathologic or it could be physiologic. Remember, it could be pathologic or it could be simply physiologic also. Physiologic can happen if the pituitary is slightly pulled up towards the hypothalamus, and so that because of that you see a CSF accumulation in the sella and you don't see the sella. Hey, the pituitary is there and it's normally functioning, but it's just slightly pulled up so that you don't see a pituitary in the cell, I just see the CSF there. So it could be physiologic as well. So it doesn't lead to any consequences at all. The patient may not have any feature that is suggestive of hypopituitarism, but it could be pathologic as well. Pathologic may be due to radiotherapy causing necrosis of the pituitary, or after Sheehan syndrome causing necrosis of the pituitary and disappearance of the pituitary, or after an apoplexy which is sometimes unnoticed that may result in disappearance of the pituitary from the sella, or even it could be a surgery. After transfemoral surgery, when you remove the pituitary, obviously this will have a history, all right, but this could be the reason why pituitary is not formed. But a lot of variety of pathologic reasons are there why you can get an empty sella, which means what you have to understand is empty sella is not always almost pathological. Let us keep a separate session on empty sella later on if there is time. But right now, this is how we have to understand. So if you don't see the pituitary in the cell and you can see the CSF, that's what you refer to as empty cell. It can be pathologic or it can be physiologic as well. And number 8, a lot of congenital conditions can produce hypopituitarism. What are the congenital conditions? It could be arising out of a genetic mutation. Usually genetic mutations arise from mutations of transcription factors that code for normal development of the pituitary. Like for example, you can have a PROP1 mutation, or you can have a POUF1 mutations, or you can have a TP1T mutations, or you can have a HESXN mutations, or even a PIT1 mutation, transcription factor mutation. All these things can result in hypopituitarism because of abnormal development of the pituitary. In this T-pit is very, very important. So this is a pit, and T-pit is really important for exams. At least remember that. Apart from that, you can get a condition called pituitary dysplasia, or that matters, it could be aplastic as well. But remember, this dysplasia is supposed to be the most common cause of congenital hypopituitarism. Very important point. Pituitary dysplasia is the most common cause of congenital hypopituitarism. All right. Then a lot of syndromic associations are there. Syndromes can produce hypopituitarism. What are the syndromes? You have Prader-Willi syndrome. You all know, you will be obsessed with Prader-Willi syndromes right from the second year. So what do you mean by Prader-Willi syndrome? I'm not going to discuss in detail right now the genetics of Prader-Willi syndrome. It's a genomic imprinting of the paternal Prader-Willi gene on chromosome number 15. So this is a simple explanation of what is a Prader-Willi syndrome is all about. You have a lot of features. Some features I will tell. The patient may be a little short. Patient may have a low IQ and a mental retardation. Patient will have hypogonadism. All right. Patients will have diabetes. That is because patient will be very, very obese, and patient will be having voracious appetite, very much increased appetite, right? So because of the high ghrelin levels, because ghrelin is supposed to increase the food intake, the behavior. Ghrelin, G stands for grow, like leptose. Leptin stands for thin. Leptose means growing thin. That's why leptin reduces the appetite, whereas ghrelin is going to increase the appetite, and these patients are going to have very high ghrelin levels. So these are very important. So some of the important aspects of Prader-Willi syndrome. But apart from that, you can get another syndrome called Lawrence-Moon-Biddle syndrome that can also have hypopituitarism. Remember, in this, you might ask me in Prader-Willi syndrome why they are short. The explanation for why they are short is because of hypopituitarism, possibly. And you have Lawrence-Moon-Biddle syndrome. So this is a very peculiar and interesting syndrome where you have a tetrad of findings. This is very important. So what are the tetrad of findings you're going to get in Lawrence-Moon-Biddle syndrome? You will get a spastic paraplegia and retinitis pigmentosa, that's RP. Apart from that, they have intellectual impairment, low IQ, and they might have short stature again. And this short stature again is due to pituitary dysfunction or hypopituitarism. That is the reason. Clear? And majority of the patients can have a moon face, a little obese, and all these things are fine. So these are the characteristic features of Lawrence-Moon-Biddle syndrome, and both these patients are short, and that is because of hypopituitarism. And third one, very, very important for exams, that is Kallmann syndrome. So what do you mean by Kallmann syndrome? More than you see this Kallmann syndrome is in medicine and endocrinology in medicine, you'll be seeing in OG most of the times. Why? Because this Kallmann syndrome is known to cause hypopituitarism, all right, but that will typically produce hypogonadism rather than anything else. So that hypogonadism is due to GnRH deficiency, gonadotropin releasing hormone deficiency. At the same time, this patient will have anosmia. This is a very characteristic feature of Kallmann syndrome. Whenever in exam you get this combination of hypopituitarism, especially this hypogonadism, that is low GnRH production, along with it, if you have anosmia, so you will result in you have to diagnose a Kallmann syndrome in exams. So hypogonadism, anosmia, Kallmann, hypogonadism, anosmia, Kallmann is equal to hypogonadism plus anosmia. That's all. You may ask me why you get an anosmia in these patients. The reason why you get an anosmia in these patients is the fact that they have absent olfactory bulbs. Because they have absent olfactory bulbs. because of the defective GnRH production, they will have a defective FSH and LH. And whenever you have a defective FSH and LH, obviously you're going to have a defective estrogen or a testosterone, obviously. Like majority of them will be females. That's why defective estrogen is very important, and progesterone also cannot be secreted. Because of that, you result in hypogonadism. Here the FSH and LH are low. Because of that, this will come under a group called hypogonadotropic hypogonadism. Hypogonadotropic hypogonadism. Clear? Obviously this is the case, isn't it? This is a central problem or a pituitary issue. So you know how it works. You have a pituitary comes to the gonads. Gonads are the ones that synthesize the estrogen or testosterone. Let us assume. And pituitary synthesizes FSH and LH, which acts on the gonads. So let us duplicate this one more time. So where is the problem and what is the problem? Suppose if we have a problem in the FSH and the LH, because of that the gonads are technically normal, anatomically normal, but functionally not working properly. That is because of the low FSH and LH from the pituitary. Obviously your estrogen progesterone will be, or estrogen and testosterone in the particular individual will be low, and this is what we refer to as a hypogonadotropic hypogonadism. Clear? Both are hypogonadism only. This is a hypogonadotropic type of hypogonadism because the FSH and LH levels are low. These are the characteristic gonadotropins. That's why it's called a hypogonadotropic hypogonadism. Similarly, if you have a problem in the gonads, so the gonads are not working properly, so there is some defect in the gonads itself, which means you will not have a sufficient production of estrogen or testosterone depending on the gender. And obviously this is the one that's going to give the feedback, you know that, to the pituitary and the hypothalamus. So that will reflexly, because the pituitary is going to sense, the hypothalamus is going to sense that the estrogen or the testosterone is going to be low in that particular individual. So they can start producing excessive amounts of FSH and LH, and that will result in a condition called hypergonadotropic hypogonadism. So both are types of hypogonadism only. Both are going to result in hypogonadism only. But what is the type of hypogonadism is very important. If you have a central issue, it's called hypogonadotropic hypogonadism. If you have a peripheral gonadal problem, you're going to result in a hypergonadotropic hypogonadism. So hypogonadotropic hypogonadism, characteristic example is pituitary issue. Any pituitary or central issue will result in a hypogonadotropic hypogonadism only. Gonadal issue, like best example for a gonadal issue is going to be, physiological example you can tell, it's a menopause or a premature ovarian failure or orchidectomies. So all these things are going to result in a gonadal problem, which can result in a hypergonadotropic hypogonadism only. But the thing that you see in a Kallmann syndrome is hypogonadotropic hypogonadism, right? So going to result in a hypogonadotropic hypogonadism. So it's a central pituitary issue, so, or a hypothalamic issue. That's the reason you are resulting in a hypogonadism in Kallmann syndrome. And if they ask you why you get anosmia in Kallmann syndrome, you have to answer it is due to absent olfactory bulb. So that's the reason why you get a anosmia in Kallmann syndrome. Okay, the next thing that is important is septo-optic dysplasia. So what do you mean by septo-optic dysplasia? This is a problem of the midline structures. That's also, this is otherwise referred to as something called a de Morsier syndrome, but this is nothing but a problem of the midline structures. What are the midline structures you have? A lot of midline structures you have. In that, the most important is the one that separates the two lateral ventricles, isn't it? This line, this septum that separates the two lateral ventricles is what we refer to as a septum pellucidum. Is one of a very, very important anatomical landmarks, especially for the radiologist, which is a very important midline structure. The diagnosis of a midline shift itself is based on the displacement of the septum pellucidum only. I'll show in the MRI in some time. Then you have another important midline structure, that is the pituitary, and over that you have the optic chiasma. So you have optic chiasma and you're going to have a pituitary as well. So these are the three important midline structures that I'm talking about. And pituitary is something dead midline in the head. In the entire cranium, pituitary is one of the central structures, like it's a midline structure, you know that. So in septo-optic dysplasia or de Morsier syndrome, we're going to have problems in this, which means there could be an absent septum pellucidum, all right. Number 2, there can be optic nerve hypoplasia or dysplasia, that the patients can have visual field defects. And number 3, patients may have pituitary dysplasia or hypoplasia. Alright, pituitary dysplasia or hypoplasia. These are 3 important things. Among these 3 things, if you have at least 2 of these 3, you will establish the diagnosis of de-Mossier syndrome or septo-optic dysplasia. Apart from that, patients may have associated olfactory bulb hypoplasia also, that can lead to Kallmann syndrome, or the patients might have associated corpus callosal defects also, problems in the corpus callosum also. But this is not come under the criteria, but still the patient may have acid problems. Why I told you all this in a very detailed way? Because of one important MRI finding that you have to know. One very important MRI finding that you have to know for sure. So this is that finding, this absent septum pellucidum, very characteristic, very important for exams. You can see here. So this thin black line is the septum pellucidum actually. That's the septum pellucidum which I have drawn, and these are the 2 lateral ventricles. Here you can see there's a single lateral ventricle, there's no septum pellucidum here. This is typical absent septum pellucidum, and this is a very important MRI picture in exam. If you see this, you can straight away diagnose this as a septo-optic dysplasia. That's it. Absent septum pellucidum. So before going into the actual clinical features of different hormone deficiencies, it's very, very important to understand the features of 2 different disorders, even though they are considered to be subtypes of each other, but 2 different disorders. One is a pituitary apoplexy, and second one is a Sheehan syndrome. I already told you, even though Sheehan is considered as a subtype of, or maybe a subclassification of apoplexy only, but a lot of authors consider this as a separate entity, because I'll tell you why. So first you have to know the etiology of pituitary apoplexy. The etiology of pituitary apoplexy is very simple. It's going to be most commonly due to a macroadenoma. Most commonly it will be a pituitary macroadenoma that's screwing up its own blood supply, which means that can result in a hemorrhage or an infarction. So pituitary macroadenoma that's screwing up its own blood supply. Either it can result in a hemorrhage into the pituitary, or it can, because the massive size of the macroadenoma, it can compromise its own blood supply and again screw up and can go for infarction, edema and inflammation in the local area. Fine. So this is the usual reason. Apart from that, you can result in apoplexy due to uncontrolled hypertension causing bleeding into the pituitary. Especially this is common if the patient has associated diabetes mellitus, or if the patient goes for a DIC, disseminated intravascular coagulation, causing bleeding into the pituitary. You would have studied DIC due to meningeal septicemia causing hemorrhage into the adrenal glands, is called as Waterhouse-Friderichsen syndrome. But here the DIC might happen and because of some sepsis, and that might result in hemorrhage into the pituitary, or very rarely it might be due to traumatic causes, but these are not common. So the most common will be always the macroadenoma screwing up its blood supply causing hemorrhage or infarction of the pituitary. Clear? Sheehan syndrome is going to happen only in the postpartum women. That is due to severe postpartum hemorrhage causing hypotension. Clear? Postpartum women due to severe postpartum hemorrhage causing hypotension. All right. So what is the mechanism? Mechanism of apoplexy, I told you, it is either a hemorrhage into the pituitary, that's a usual phenomenon, or it can be even a necrosis due to infarction. Infarction of the pituitary. Clear? Necrosis, infarction of the pituitary, that is due to variable reasons. I told you already. It's necrosis or infarction causing inflammation, edema of the pituitary. But on the other hand, Sheehan syndrome is only due to infarction, postpartum infarction or necrosis of the pituitary. It's not a hemorrhage, it's only a necrosis or infarction of the pituitary, but it will happen only in postpartum women. I told you, only if it happens in postpartum due to PPH, you are going to call it as Sheehan syndrome. But here the patients will not have history of this postpartum period in the exam. So it's not a postpartum disease. It's a postpartum disease causing infarction, necrosis, typically Sheehan syndrome only. And why categorically they are affecting only the postpartum women, not any other one? Now, like the reason is because if you take this a normal pituitary, in the postpartum period, I'm going to have something like this, which means there will be hypertrophy of the antipituitary, and especially one important area is going to get hypertrophy, that is the lactotrophs. These lactotrophs or the mammotrophs are the ones that will be seriously hypertrophied in the postpartum period, or in the peripartum period, at least during the parturition and during the third trimester. This lactotrophs going to hypertrophy like anything. That is because they have to secrete prolactin, which is needed to produce the breast milk that has to support the child, newborn child. It's very, very important. So that's why they go for hypertrophy, and that is the reason. Suppose if I am having a normal patient is having a hypotension and shock, it has very least effect on the pituitary. It doesn't have any much effects. But a postpartum woman, due to postpartum hemorrhage causing hypotension and shock, is very significant because this pituitary needs a very high blood supply, but this hypotension can compromise this pituitary's blood supply and they can go for infarction and necrosis. And who's going to be the maximally affected one? That's the lactotrophs. Other areas will be minimally only affected, but these lactotrophs are the ones that are going to be maximally affected. And it's a very subacute process. We'll discuss in the next point. So, clinical feature like presentation wise, it's going to be very acute in presentation. But whereas your Sheehan syndrome is going to be more subacute to chronic, which means it will not be dramatic presentation. It will be more of a subacute to chronic presentation. So in the sense, what will be the first sign, clinical feature or clinical sign of a Sheehan syndrome? If somebody asks you, definitely you are going to answer it is lactational failure. Because the lactotrophs are the first that are going to be affected because they are the ones that need more blood supply, and they are the ones that are more prone for necrosis in the postpartum period due to hypotension. So that is really important, and lactation failure is often going to be the first evidence of a Sheehan syndrome, and it's very subacute. It's not going to present like very dramatic like headache, visual field defects and mass effects like how apoplexy will present, which I'll go to discuss. So second, plus or minus, the Sheehan syndrome patients may have other hormone deficiencies also. Other hormone deficiencies, for example, they may have a low growth hormone, they may have a low gonadotropins in the form of reduced FSH and LH, which can result in amenorrhea over a long period of time, more than expected after pregnancy. They can have a low TSH, and because of that, they will have a low T4, resulting in a central hypothyroidism like picture. They may also have a low ACTH, which means they can have a low cortisol, making a secondary adrenal insufficiency picture. So they can have adrenal insufficiency also, and they are more prone for hypotension and shock because they have low cortisol. They cannot support these patients in times of stress, because cortisol is a very important hormone during stressful scenarios. So they can go for shock during stressful states. Clear? But the first sign is almost always a lactational failure in a Sheehan syndrome. But apoplexy is something different. They will be more dramatic in presentation, and it's one of the neurosurgical emergencies where they are going to present with mass effects of the pituitary. So whenever pituitary is going to produce mass effects, you have a lot of non-specific signs, and you have some specific, or at least a relatively specific sign with respect to the pituitary. What are the non-specific signs of any mass effect? So obviously it's going to be the headache, and in apoplexy, the most common clinical feature will be the headache only. Sudden acute onset headache. Very, very important. That is not seen in Sheehan syndrome at all. It's very subacute. You don't have a headache, but here you can definitely have a headache, which is going to be the most common clinical feature. Apart from that, they might have a nausea and vomiting, and which is also going to come under non-specific mass effect, that is due to raised ICP. And specific with respect to the pituitary, you have to know a little bit of anatomy about it. So this is the sella, and here is where your pituitary is, and this is where your optic chiasma is, and you have a cavernous sinus. All right, so on the either side you're going to have a cavernous sinus, and this cavernous sinus is having a lot of blood, and it's going to communicate with each other as well. All right, so this is going to communicate with each other also, and you have a lot of nerves that are suspended in the cavernous sinus. You have third nerve, fourth nerve, fifth nerve, 5-1, 5-2, 6. Lot of nerves are there, except the mandibular nerve, that 3-4, 5-6 complex. A lot of them are going to be suspended in the cavernous sinus. And you also have a internal carotid artery. All right, so you also have internal carotid artery that is suspended in the cavernous sinus only. This is the cavernous portion of the internal carotid artery. There is a separate entity called cavernous portion of the internal carotid artery where they are located in the cavernous sinus. So anything that affects the pituitary, for example, let me say there is some problem in the pituitary that is causing enlargement of the pituitary area, which means the first that is going to compress is the central portion of the chiasma. So which means the central crossing fibers, central chiasma will be affected. So first they are going to affect the central chiasma will be compressed. So it's called central chiasmal compression, number one. And second, they can go and compress on the cavernous sinus associated nerves also. That's also possible. So these are the two things that you're going to get. So what are the features of a central chiasmal lesion? So whenever you get a central chiasmal lesion or a central optic chiasmal compression, you are going to get a very characteristic type of visual field defect. Obviously, it will result in a visual field defect. And what is the characteristic type of a visual field defect you're going to get? That is called a bitemporal hemianopia. Remember, we have a whole lot of discussion on this visual field defects, but right now I'm going to discuss only a relatively specific thing for pituitary, that is bitemporal hemianopia, but we have a separate discussion in the central nervous system where what are the different types of visual field defects and how will you approach a visual field defect. But right now, trust me, central chiasmal lesion will result in a bitemporal hemianopia. But remember, in this itself, you have to see whether what is the pattern of bitemporal hemianopia, whether it is superior loss more than inferior loss or inferior loss is more than the superior loss. Why this is important? Because you can see that pituitary lesions, expanding pituitary lesions will affect the optic chiasma from the bottom, which means the inferior fibers are affected more. For example, if I zoom in and show you, you can see pituitary is going to affect the inferior fibers more. Remember, these inferior fibers carry the superior world, and the superior fibers in the optic tract is going to carry the inferior world. So whenever the inferior chiasma is affected, which means superior more than inferior, means it indicates a inferior chiasmal lesion. So when you have an inferior chiasmal lesion, means in this condition it's going to be a pituitary adenoma only in exam. Only pituitary adenoma can cause this picture. Supposedly, if inferior world is affected more than the superior world, which means they are affecting the inferior world fibers which are carried on the superior surface or on the upper surface of the optic chiasma and the optic tract, which means it's a superior chiasmal lesion. Superior chiasmal lesion. Superior chiasmal lesion means it must be a supracellular lesion, it cannot be a cellular lesion. Pituitary adenoma is a cellular lesion, but definitely superior chiasmal lesion means it must be a supracellular lesion. Very commonly it will be a craniopharyngioma. Craniopharyngioma, which must be a supracellular tumor. It's a supracellular tumor, which we'll discuss in some time about that. Anyway, we have a good discussion in the CNS also, but right now we'll discuss in small detail in the next upcoming section. Clear? So which means craniopharyngioma is going to compress from the top, and they're going to involve the superior fibers. So they'll produce inferior vision loss more than the superior vision loss. Alright. So if I draw the vision, what the patient sees, and if you want to put a defect in this patient, the defect will be looking something like this, this is what we refer to as a bitemporal hemianopia. This bitemporal and binasal hemianopias are also referred as heteronymous hemianopias. I'm not going to discuss about those right now. And if you are going to affect the superior loss, superior vision more than inferior vision, obviously this goes towards a pituitary adenoma. Alright. And if I'm going to affect the inferior vision more than the superior vision, so obviously we know that this usually goes towards a craniopharyngioma. Alright, so this is a very important thing to understand. So both will cause bitemporal hemianopia only, but which is affected more will tell you what is the lesion and where is the lesion. Because bitemporal hemianopia means itself, it's a central chiasmal lesion. That's all. It's a central chiasmal compression. Fine. I told you about the visual field defects. Definitely they will result in visual field defects. Number one, we thought about this visual field defects. And number two, I also told the cranial nerves may be damaged. So this pituitary mass effect can result in cranial nerve palsies also. This cranial nerve palsy may result in diplopia, typically because they have this 3, 4, 5, 6 complex, and the most common cranial nerve affected by enlarging pituitary lesion is the third cranial nerve. It's the most common cranial nerve that is affected, which may lead to diplopia. Rare entity, but still important. And third thing, this enlarging pituitary lesion may compress on the pituitary, normally functioning pituitary itself, and they can cause pituitary hormone deficiencies. Clear? Pituitary hormone deficiencies, like they can produce low growth hormone, they can produce low gonadotropins like FSH and LH and result in amenorrhea, they can result in low TSH production, they can result in low ACTH production, resulting in low cortisol, secondary adrenal insufficiency, and shock whenever the patient goes for some crisis states, or they can even have a low ADH production causing diabetes. I didn't write it, this is possible here also in Sheehan syndrome also. It's not like they may not happen here. Low ADH can result in diabetes, but these are very rare. Usually these are anteropituitary issues, not postpituitary, but they can extend into the and postpituitary also, plus or minus. Clear? Saying diabetes insipidus. Okay, all right. So among all this, if they ask you which is the first hormone to be replaced, what you will tell? I mean, in both these conditions, you might end up with hormone deficiencies. A lot of hormones may be deficient in the anterior, maybe in the posterior pituitary also, but what is the first hormone you have to replace here? Very simple, no? Like, if you have a GHD, let us see one by one. If you have a growth hormone deficiency, in adults, are you going to result in any problem? Not much, no, like, not much. I'm not going to talk about the actual problems due to growth hormone right now. I'll tell you in some time, but are they going to result in any life-threatening issues? I don't think so. Low gonadotropin in adults, only amenorrhea, any life-threatening issue? Absolutely not. Low TSH, low thyroxine, it's very chronic. Acutely or in the long run also, they're not going to result in any life-threatening issue. No, not at all. But remember one important point, this is a secondary hypothyroidism, not a central hypothyroidism. In a central hypothyroidism, usually these patients don't go for mixed edema. Whenever you encounter central hypothyroidism, it's a very, very important point. Only in primary hypothyroidism, mixed edema is very common. In secondary hypothyroidism, mixed edema is extremely rare. And in fact, you don't get mixed edema in a secondary hypothyroidism. So mixed edema coma again is a very, very rare entity in secondary hypothyroidism or a central hypothyroidism. So that's why I'm telling you, it's not life-threatening in this case. Low ADH again is immediately not life-threatening unless it's very severe, but what is definitely life-threatening is low cortisol. Surely life-threatening, because cortisol being a stress hormone, if you don't have cortisol, definitely the patient is going to die during times of stress because they cannot cope up with the stress. See the adrenal chapter to understand how cortisol is important during stressful scenarios. Clear? Very, 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 very important point. So again, life-threatening. Again, even in these patients with apoplexy, the most important is the cortisol. If you lose the cortisol, they are prone for shock and hypotension during stress. That is the reason, by whatever may be the cause of hypopituitarism, my first hormone to be replaced will be hydrocortisone. What is hydrocortisone? It's very simple. Hydrocortisone is nothing but a synthetic cortisol. We're having cortisol, isn't it? So cortisol in pharmacological form, you call it as hydrocortisone. That's all. It's just a cortisol. That's all. So that's given in tablet form or injection form. That's hydrocortisone. So that's the first treatment that you have to give in any hypopituitarism case or any adrenal insufficiency case or any hypopituitarism case, whatever may be the cause. The first treatment I'm going to prescribe is hydrocortisone. This is not to reduce the inflammation or reduce the edema. It's to actually replace the cortisol, which is low in these patients. That's the idea. So this is the difference between apoplexy and Sheehan syndrome. Clear? So apart from that, you can get certain clinical features due to certain hormone deficiencies itself. So what are the clinical features due to certain hormone deficiencies? First, what will happen due to growth hormone deficiency? Let us see one by one. So what will be the clinical features and what are the investigations you can do? Growth hormone deficiency in children is going to result in a short stature. We know that already. So this is called a pituitary dwarfism, right? If it's due to growth hormone receptor defect, there is another entity. You have to note this also. Suppose if the pituitary is not producing sufficient growth hormone, that is different. So if the growth hormone levels are low, that's fine. That's all right. That's going to result in a pituitary dwarfism. Suppose if the pituitary is producing a normal amount of growth hormone, but the peripheral growth hormone receptors are not responding. So you have a growth hormone receptor. This growth hormone receptor, it's going to work by JAK-STAT principle. We know that already. JAK-STAT receptor, and this is mutated, and if this is not working, which means the growth hormone resistance in this condition. So because of that, again you can get a dwarfism, and this type of dwarfism we call it as Laron dwarfism, and it's called as growth hormone insensitivity syndrome. Clear? This is called a growth hormone insensitivity syndrome. Clear? And to understand the investigatory aspects of growth hormone deficiency, so how will you diagnose a growth hormone deficiency? Before that, what will be the adult features? Adults cannot go for reduced weight because their epiphyse is fused and the height is permanent. You cannot reduce the height unless and until you break the bones and shorten the height. It's not possible. So even growth hormone deficiency is not going to cause shortening of height. The patients will remain same height in adults, but there will be some very vague features. Very vague features, like patients may go for fatigue, weight gain, along with increased body fat to lean body mass. So when you compare the lean body mass, the body fat will be a little bit high because growth hormone, we'll discuss, because I have not discussed the growth hormone physiology yet. In hyperpituitarism, especially when you are discussing about acromegaly, I'm going to discuss the growth hormone in detail. By that time, we'll understand growth hormone. One of the direct effects of growth hormone is to promote lipolysis, because probably because of reduced lipolysis, these patients may have increased body fat. Fine. At the same time, these patients will have increased risk of osteoporosis due to unknown reasons, and because of that they might result in a fracture, and these patients have reduced psychological well-being, which means they feel unwell all the time. We don't know why. And they have increased insulin sensitivity, which means they are prone for hypoglycemia. I'm not telling they will have recurrent episodes of hypoglycemia, but they are prone for hypoglycemia, that's all. Why increase insulin sensitivity? Because growth hormone, on the direct effects of growth hormone is to increase the blood glucose levels. It's the one agent that acts like a glucagon and increases the blood glucose. That acts like cortisol and increases the blood glucose levels. Clear? So, but because of the low growth hormone in adults, they're at risk of hypoglycemia, and that is what we define as something called increased insulin sensitivity, prone for hypoglycemia, because growth hormone is a hyperglycemic hormone that is not there, prone for hypoglycemia. That's it. Children, whether you do investigations, children's, yes, definitely you have to test for growth hormone in all short stature patients. Whenever a child is dwarf and is not growing, definitely you have to test for growth hormone insufficient. There is no doubt about that. But in adults, whether you test or not is very, very controversial. Why? Because testing means you have to treat the patients also. Whether to treat these patients or not, again, it's very controversial because these are very vague symptoms, and whether treating with a growth hormone will really cause improvement in these symptoms or not, and we don't know. That is the reason why testing itself is very controversial in adults. But who to test in adults? Who to test? Only those patients who are having high risk of growth hormone deficiency. Probably best examples will be if a patient is having a suspected Sheehan syndrome, which means a severe postpartum hemorrhage is there and patient had a lactation failure, and that patient is coming with all these features. You might suspect a growth hormone deficiency and you can do a growth hormone testing. Or if the patient had a pituitary radiotherapy and after that post-pituitary radiotherapy coming with these features, again you can do a growth hormone testing. Or after a transfemoral surgery, the patient comes with these symptoms, adult patient, then you can test for a growth hormone deficiency. But in general, we don't do a growth hormone deficiency testing for all the patients. Only for patients who are at risk of developing these problems are going to be tested for growth hormone deficiency. And again, it's a very controversial thing in adults. Treatment as well as testing is controversial, but children, definitely treatment and testing is surely indicated. If there is a growth hormone deficiency, you have to treat them, otherwise they will not attain the terminal height. It's not possible. So this is really, really important to understand. Clear? And what is a test? What is the investigation that you're going to do? I told you have to do the investigation, but what is the investigation? Remember, first investigation you do is something called a serum IGF-1. That's what you have to see. The serum IGF-1 is low or serum IGF-1 is normal. Remember, the serum IGF-1 is a very good test. Suppose if it's low, means surely it tells you that the patient is having a growth hormone deficiency. There is no doubt about that. Because why serum IGF-1 we are measuring is because growth hormone has direct effects as well as indirect effects. So whenever the growth hormone is released from the pituitary, it has two type of effects. One is called direct effects, like lipolysis, hyperglycemia. All these are direct effects. We'll discuss in in the next video. And there are a lot of indirect effects also. Remember, these indirect effects are actually mediated by release of certain somatomedins called IGF-1. There are a lot of somatomedins are there, but IGF-1 is a very important somatomedin. And through the somatomedins only, they exert a lot of indirect effects, like many growth effects are exerted through the somatomedins only. So that is why this IGF-1 is also a marker of how much growth hormone is there. Suppose whenever IGF-1 levels are reduced, which means growth hormone levels also should be reduced. Remember, one of the important areas, important organs that produces this IGF-1 is the liver. Again, which I'll tell you. I mean, now I'm only telling you certain basic things, but I'll discuss all these things in detail in the subsequent videos. But liver is one major organ which is susceptible to this indirect effect of growth hormone, resulting in release of IGF-1. And this IGF-1 is going to exert a lot of peripheral effects. That's why I'm telling you. So low IGF-1 usually indicates a growth hormone deficiency. Suppose if the IGF-1 is normal, you have to see what is the suspicion of growth hormone deficiency. If the suspicion of growth hormone deficiency is high or low, low means no need of any other testing, no further testing indicated. If the suspicion of growth hormone deficiency is high and the IGF-1 level is normal, it can be falsely normal sometimes. So that is why you have to do confirmatory testing. Confirm this suspicion by doing certain provocative testing, because I told you provocative or stimulatory testing you will do when the patient is actually having a deficiency. Here you are suspecting growth hormone deficiency, that's why we are trying to do a provocative or a stimulative testing. What is the idea here? Quite simple. In any provocative or stimulatory testing, first let us assume here the somatotrophs is the glands of question, so that are secreting the growth hormone. Here you are suspecting a problem in the somatotroph, so that you are suspecting that growth hormone is low, but you don't know. Clear? So that's the idea. But you cannot take the growth hormone directly, because I told you there are a lot of fluctuations will be there and it will be not a correct thing. So you have to do some stimulatory or provocation testing, especially for hormones that are related to this HPA axis. So I'm trying to stimulate this gland. How I can stimulate this gland? By many means. Let me tell you. So before that, you understand one important thing, where one of the important functions of the somatotrophs is to release growth hormone. Whenever growth hormone is released in excess amounts, this excessive growth hormone can result in increased glucose. This increased glucose may result in feedback inhibition of the somatotrophs. Clear? So feedback inhibition of the somatotrophs, so that this is a typical negative feedback loop, so that the growth hormone levels will be maintained in the normal range. So this glucose is a very important feedback to the somatotrophs that can control the growth hormone levels. This is an internal control that is existing. The opposite is true. For example, if you have a low glucose, that is going to act as a stimulatory signal to the somatotrophs, so that your growth hormone levels should actually increase, which means this is a very important physiological signal. This hypoglycemia is a very important physiological signal that can increase the amounts of growth hormone, which means this hypoglycemia is a physiological provocative signal or a physiological provocative test. That's what I'm trying to utilize here. I'm going to induce hypoglycemia to the patient. If I induce hypoglycemia, a controlled hypoglycemia to the patient, I should expect what should be the normal response. A normal response should be increased growth hormone levels. Clear? You have a cutoff for all these things. Right now, I'm not going to discuss on the cutoffs. But still, if you see low growth hormone, even after giving a hypoglycemic stimulus to the somatotrophs, if still the growth hormone is still low and less than the cutoff that we have determined, so this is definitely abnormal, and that can confirm it's a growth hormone deficiency. That's a gold standard test. And this test, how you're going to induce hypoglycemia by giving insulin, and this test is what we are going to call as insulin tolerance test. One of the gold standard tests, insulin tolerance test, very, very important. And this is how you test for a growth hormone deficiency, suspected growth hormone deficiency, and you have a lot of other testing also available. What are the other testing? You can do other provocative testing. Apart from insulin tolerance test, you can stimulate this growth hormone directly by giving growth hormone releasing hormone. Yes, this is a natural, again a physiologic stimulus that stimulates the somatotrophs to secrete excessive growth hormone. So growth hormone releasing hormone often we combine with arginine. So which means your amino acids, especially proteins, are also very important potent stimulus for growth hormone release. That's why we are combining these two by giving something called a GHRH arginine test. Usually this GHRH arginine test is supposed to be the best test for detecting growth hormone deficiency, but this is a little bit costly and this is not available in all the areas. That is why insulin tolerance test is a first test that is preferred, and it's also a gold standard test. But if this insulin tolerance is contraindicated due to some reason, for example, in patients who are already prone for severe hypoglycemic consequences, already you have gone for severe hypoglycemic sequelae and hypoglycemic consequences, you cannot do this test, they might die. And patients who have had a recent MI, or patients who are having seizure prone tendency, in all these patients it's very difficult to do these insulin tolerances. In those conditions you can prefer a GHRH arginine test. This is also a very important provocative test. And you have another test called a Massey-Morlin test. How Massey-Morlin test does, because this is a very important test. Why? Because this is the only test that is available as an oral test, which means this Massey-Morlin can be given as an oral compound. That's why. So what is this Massey-Morlin? Massey-Morlin is a ghrelin analog or a ghrelin agonist. The analog ghrelin agonist, which means they are going to increase the ghrelin levels. Which means this ghrelin level is a very important stimulator of growth hormone release. Clear? So ghrelin has to increase the growth hormone. That's a normal response. But if ghrelin does not increase growth hormone, that you can use it as a confirmatory test for growth hormone deficiency. Clear? So Massey-Morlin test, importance is it's the only oral test that's what we're going to use. Apart from that, you have other stimulatory tests which are not that much important, like giving clonidine and testing, outdated. You can use glucagon and test, outdated, and L-DOPA you can give and test, again outdated. So currently one of these three tests only you have to do, either insulin tolerance, GHRH, arginine, or Massey-Morlin. First test that generally preferred as a gold standard is this insulin tolerance test only. If suppose if it's contraindicated, or if you have the facility to do this GHRH arginine test, that will be the best test. Clear? GHRH arginine. If you have the facility, please do that. Clear? So these are the tests that you can prefer for diagnosing growth hormone deficiency. Like growth hormone deficiency itself is a huge entity. So this is growth hormone deficiency. Whether you treat growth hormone deficiency or not, again depends on whether it's a child or an adult. In child, definitely yes, treatment has to be done in a child. Definitely treatment has to be done, because otherwise the child will not grow at all. What is the growth hormone dose that you're going to give? Obviously it's a recombinant growth hormone. That's what you're going to give. In children, the dose is approximately 0.16 to 0.24 milligram per kilogram. Clear? So this is the starting dose usually, and after this you are going to monitor the patients with serum IGF-1 levels. And that should become normal. Clear? That's the target. So if serum IGF-1 is already normal, then no need to increase the dose. If the serum IGF-1 is still persistently low even after giving this dose of growth hormone, then you can titrate by increasing the dose by 10 to 20% periodically, like by monitoring serum IGF-1. The target is serum IGF-1 should become normal. So that's the idea. So this is the dose of a recombinant growth hormone. But you have a lot of side effects in children by giving this growth hormone, recombinant growth hormone. The most important and most significant is going to be the headache. Headache is a very important and significant side effect. And remember, few of these patients, not all the patients, few of these patients may also progress to a disorder called idiopathic intracranial hypertension. Around 10 to 20% who receive this growth hormone can get a disorder called idiopathic intracranial hypertension, otherwise called as, previously referred to as, benign intracranial hypertension, otherwise called as pseudotumor cerebri. Very important side effect of a growth hormone therapy. And second, they can result in slipped capital femoral epiphysis. Again, very important side effect as far as children is concerned, slipped capital femoral epiphysis. And third thing, they can develop scoliosis Clear? And they can develop raised intraocular pressures also, and glaucoma. So all these things are possible, but very important in exam, they'll ask you these two things: idiopathic intracranial hypertension, but not all patients develop IH. Headache is very common, but a handful of patients who have headache may progress to idiopathic intracranial hypertension also, may have elevated CSF pressure, that's what we call IH. And sleep capital femoral epiphysis is again very, very important. As I told you, in adults, it's very, very controversial. Not only testing is controversial, even treatment in adults is controversial. So how we are going to treat this patient's usual dose of growth hormone is approximately 0.3 milligram per day. That's the usual starting dose. This is where you're going to start, or you can even write it as 2 to 5 microgram per kilogram per day. Both are correct, but 0.3 milligram per day. In children, I start with 0.16 to 0.24. Here I'm going to start with 0.3 milligram per day. And again, I'm going to monitor the response with the help of serum IGF-1, which is, the marker. It has to become normal. So that's the idea. So if it doesn't become normal, I'm going to increase the dose by 10 to 20%, or increase the dose by 1 to 2 microgram per kilogram. So you are going to increase, or 10 to 20% you are going to increase periodically depending on the IGF-1 response. The target is it should become normal, so that accordingly you can up titrate or down titrate your growth hormone dose, recombinant growth hormone dose. In adults, you will get a variety of other side effects, peculiar side effects, like you can get edema because growth hormone tends to retain sodium. So that's again functions I'll discuss later on. So peripheral edema, they can result in arthralgias, and they can result in carpal tunnel syndrome. They can result in paresthesias. They can result in glucose intolerance. Remember, growth hormone deficiency result in insulin sensitivity, but here it results in insulin resistance. That's what glucose intolerance we mean. And they can even progress towards a frank diabetes mellitus. These are some of the side effects of growth hormone therapy in adults. So this is entire thing about the growth hormone, which I have told you, growth hormone deficiency and how to diagnose the symptoms, the treatment, all these things we have discussed in detail. And second thing, you have prolactin deficiency. Prolactin deficiency, it's very important only in Sheehan syndrome. Very important Sheehan syndrome. There only it's important, where a postpartum female will go for lactational failure. But it is typically not tested, not treated as well. So there is no need to give prolactin replacement. The baby can be instead treated with artificial feeding, because prolactin doesn't have any much significance when it is in deficient states in adult patients. So apart from this milk production function, so you can give the supplementary feeds to the child and that's enough. So you cannot test or you cannot treat for prolactin deficiency. Third one, you have ACTH deficiency. Remember, ACTH deficiency is going to result in secondary adrenal insufficiency. You have two forms of adrenal insufficiency, isn't it? So pituitary is going to release ACTH. This ACTH is going to act on the adrenal gland. This ACTH is going to act on the adrenal gland. This adrenal gland is going to produce cortisol. Clear? You have two types of adrenal insufficiency. Number one is primary adrenal insufficiency, where the problem is in the adrenal gland itself. The cortisol is low, and this will give a feedback resulting in excessive ACTH. This is called a primary adrenal insufficiency. But pituitary problem will not result in primary adrenal insufficiency. It's going to result in secondary adrenal insufficiency, where the problem is in the pituitary. Because of that, there will be low ACTH. Because of that, there will be low cortisol. Here, the adrenals are okay, at least anatomically and functionally. Just low cortisol is due to low ACTH. So low ACTH, low cortisol indicates it's a secondary adrenal insufficiency. There are a lot of differences you will get between primary and secondary adrenal insufficiency. The most important being the salt wasting. Even though we have a whole lot of chapter on adrenal insufficiency, which I will discuss in detail there, the salt wasting is a very, very important feature of a primary adrenal insufficiency, where you don't have any salt wasting here. But remember, both are prone for developing adrenal crisis, because in both these patients, cortisol levels are low. That is the reason in both these patients, these patients are actually prone for shock and adrenal crisis. Both can go for crisis and shock. Clear? So that is the reason why both these patients has to be replaced with hydrocortisone. Hydrocortisone is a very important therapy for both these patients. Hydrocortisone is a very, very important therapy for both these patients. Clear? But this patient, since they have salt wasting also, they should be given fludrocortisone, primary adrenal insufficiency patients. But these patients generally do not need fludrocortisone, they just need a hydrocortisone because they have only problem with the cortisol and they don't have salt wasting at all. Clear? No salt wasting here in secondary adrenal insufficiency. That is why pituitary problem causing secondary adrenal insufficiency. That's what our concern right now, hypopituitarism. So you need only treatment with hydrocortisone. You generally don't need treatment with fludrocortisone because there is no salt wasting. Very, very important. Clear? And similarly, hyperkalemia and metabolic acidosis will be a feature of primary adrenal insufficiency only, whereas no hyperkalemia and no metabolic acidosis here, usually. So they only go for this shock and hypotension in times of crisis and stressful situations. That is because of low cortisol. Clear? So that's what is important to understand, a secondary adrenal insufficiency. But for diagnosing an adrenal insufficiency, primary or secondary, what is the test you will do? First test that I'm going to do is the serum cortisol. If serum cortisol less than 3 or 3 to 18 or more than 18. Remember, more than 18 rules out adrenal insufficiency. Less than 3 confirms there is some form of adrenal insufficiency, but I don't know whether it is primary or secondary. If it is 3 to 18, it's something in the normal range. So this is a normal cortisol. So we don't know whether you have to diagnose adrenal insufficiency or not in this scenario, but so since it's confusing, you have to do provocation testing because we are suspecting a low state, deficiency state. So you have to do a provocation or stimulation testing, that's called ACTH stimulation test, where I'll inject some amount of ACTH, which I'll tell you in some time how much amount. So after injecting that ACTH, after 1 hour, I will check for the serum cortisol again. If serum cortisol is less than 18 or serum cortisol is more than 18 after stimulation. After stimulation, if it's more than 18, it rules out the diagnosis. If less than 18, again it confirms the diagnosis, which means now I know it's a confirmed diagnosis, which means confirm means I know it's just an adrenal insufficiency. I don't know whether it is a primary or secondary. To diagnose that whether it's a primary or secondary, it's very easy. Do ACTH levels. If ACTH levels are low or ACTH levels are high. If ACTH levels are high, it must be a primary adrenal insufficiency. If ACTH levels are low, it must be a secondary adrenal insufficiency. More details I will be discussing in adrenal insufficiency in adrenal gland, but still this is how you evaluate a adrenal insufficiency. And if they ask you when to do a cortisol level in a adrenal insufficiency, suspect adrenal insufficiency, you have to do a 8 to 9 a.m. cortisol. This is a standard area. I prefer 8 a.m. cortisol, but you can do 8 to 9 a.m. serum cortisol, standard, like for testing adrenal insufficiency. Clear? Fine. So this is how you evaluate adrenal insufficiency, and what to treat and how to treat the secondary adrenal insufficiency I have also told. And this is a very, very important aspect. This giving a hydrocortisone is a very important aspect of any adrenal insufficiency, including secondary adrenal insufficiency due to pituitary failure, because otherwise the patient is more prone for shock, hypotension and death during crisis situations. And fourth, TSH. Very simple. Obviously, whenever you have a low T4, it confirms it's a hypothyroidism. Clear? It's a overt hypothyroidism. It's an overt hypothyroidism. All right. So now you see the TSH levels. TSH levels, whether it is increased or whether it is low. If it is increased, it tells you it's a primary hypothyroidism. If it is low, it tells you it's a secondary hypothyroidism. Clear? Even if the TSH is normal in the presence of low T4, it's an insufficient response only. Still, I will call it as a secondary or a central hypothyroidism only. Very simple. But your exams will be very simple. Like they'll be giving only low T4 with low TSH. So easily you can diagnose both the arrows are moving in the same direction. It's a central cause. It's a secondary hypothyroidism. Obviously, treatment is very simple here. You are going to only treat with levothyroxine. Dose, everything we'll discuss in the thyroid chapter. Number 5, you have FSH and the LH. Clear? These are the gonadotropins. Whenever you have low FSH and LH due to pituitary insufficiency, that's going to result in a hypogonadotropic hypogonadism. We have discussed this already. Hypogonadotropic hypogonadism, which means in a female is going to result in amenorrhea, loss of libido, infertility, and lot of other conditions like osteoporosis. Lot of things can happen because osteoporosis, that is because of low estrogen and low testosterone. In female it's a low estrogen. That's why they develop osteoporosis. A lot of reasons are there. So in a male, you can result in loss of libido, sometimes even erectile dysfunction, and males also can be developing osteoporosis. So a lot of potential issues are there because of this hypogonadism. That is because of low testosterone and low estrogen. Clear? So you have to address this issue. I mean, you can just see the estrogen and testosterone levels directly, which will be low, obviously. And if you take the FSH and LH next, definitely it will be low. Definitely it confirms it's a hypogonadotropic hypogonadism only. Treatment, actually, if you want, you can treat them, not an issue. But again, treatment is very controversial. In females of reproductive age group, if symptomatic, you can treat, otherwise no needed. Similarly, in males, if they are symptomatic, you can treat, especially those patients with reproductive age group. Apart from that, it's very controversial again, whether to treat with this testosterone, estrogen, androgens or not. It's very controversial. And finally, last but not the least, you are going to have a low ADH deficiency. Because of low ADH, you might result in a central, or otherwise referred to as a cranial diabetes insipidus. Remember, this is very common in patients who are having a infiltrative lesion and a metastatic lesion. There only will get more of a diabetes insipidus. But due to a tumor causing diabetes insipidus is very rare. Antipituitary tumor causing diabetes insipidus. Similarly, a postpartum necrosis or apoplexy causing diabetes insipidus is again very rare. And similarly, in the post-operative phase after a transfemoral surgery, you can get diabetes insipidus, or usually it will be transient, which we'll discuss in some time. So these are some of the important things that you have to know. And diabetes insipidus, how to diagnose and how to treat is again a very huge entity. For cranial diabetes insipidus, typically you are going to treat with desmopressin acetate, which is also referred to as DDAVP. It's a synthetic form of vasopressin. That's why it's called a desmopressin, DDAVP. It's a selective agonist at V2 receptors. It's more selective for V2 more than V1 receptors. So you can use this desmopressin as a treatment for this diabetes insipidus. But how to diagnose, it's something beyond the scope of the current chapter's discussion, but we are going to discuss in great detail in the hyponatremia and the diabetes insipidus chapter in the subsequent sections. So I think we have covered great detail on hypopituitarism and related causes. So with this, I will close down this chapter. I think you have understood a lot of stuff. A lot of important aspects are there in this. But in this next, in the next section, in the next video, we'll be discussing on hyperpituitarism and overview of pituitary adenomas and tumors that can be seen in the pituitary area.